So I always, when I have family members or patients who are giving me like a little bit of pushback on, I don't think it's a disease, I think it's like moral failing or weak will or whatever, I always just equate things like I head straight to diabetes, cancer, heart disease, whatever. And I'm like, would you say this, think this, feel this about someone with another disease? The way that we describe all diseases as biopsychosocial is really taking three components and putting them into one word. So we take bio, meaning biology, there are physical symptoms, right? And then psycho, being psychology, there are mental, emotional symptoms. And then social, meaning there are environmental and familial symptoms. So you've got symptoms in all of those categories for something to be a disease.
Welcome to the Therapy Show podcast. I'm your host, Lisa Mustard. In each episode, I interview a seasoned and knowledgeable talk therapist from the counseling world to glean valuable insights, techniques, and tools that you can apply to your practice and your life. And if you're considering a career in the counseling field or just want to hear about what it's like to be a talk therapist, then this is the podcast for you. Well, hey guys, welcome back to another episode of The Therapy Show. This episode, an overview of addiction and treatment models, will be a Pocourse, which means you can earn a continuing education contact hour from it. So how does that work? Listen to the episode on your preferred podcast platform. And if you decide you want to grab the contact hour, head to my site, lisamustard.com, click on Podcourses, and then click purchase. And did you know your first Pocourse is free? Just be sure to fill out the form on my site and I'll email you over a code that gives you your first contact hour for free. And yes, I'm a NBCC approved provider and my goal is to provide you with convenient and affordable on-the-go education that helps you be a better therapist. So this Pocourse is an interview with Katie Turman, LMSW here in South Carolina. Katie received her BS in social work from Columbia College and went on to obtain her master's in social work from the University of South Carolina. Katie is also a licensed addiction counselor and has worked in the field of addiction recovery for almost 20 years. And in this interview, she's going to cover three main objectives, including an overview of addiction, treatment models, and a discussion on the roles dopamine and oxytocin play. I want to let y'all know ahead of time that the audio quality isn't the best, yet the content is so good. We hope you find value in this episode. Well, hey everyone, welcome back to another episode of The Therapy Show. I'm your host, Lisa Mustard, and today's guest is a friend of mine. I've known her for many years. She is an incredible therapist, amazing at what she does, and she's helped hundreds and hundreds of people over the past, I think I can say 20 years now, right?
Yeah, it's getting close, if not right on it, yeah.
So welcome to the show, Katie Turman. It's awesome to have you.
Thank you. Thank you. It's really cool to be here. I'm super intimidated, I will say. I've seen your previous guest list. So I'm in company of people much higher caliber than me. So I'm really honored to be here.
Well, I'm excited to have you. And it's funny that you say that because when I first had this idea for the show, I don't know, 2.5 years ago, I wrote down a list of all the people that I wanted to have on the show and create Podcourses with. And you were like number one or number two. Do you remember that time I came to the center and I was like, hey, I have this idea. And you were like, okay.
Yeah, I do. Yeah. What's funny is some of what I'm talking about now, I think I mentioned to you then. And I was like, hey, I've just started talking about this thing and started kind of like looking into the research of this one thing. Back then, if I had gone on, it would have been really tentative and super like new, but now it's something that's a little more solidified and actually, coolly enough, like more known in the field. I'm not the first to say these things now.
Right.
It was really new back then.
That's exciting. So I would love for you to introduce yourself and tell our listeners like who you are, what you do, and your experience, because I think they'll really appreciate it.
Sure. Cool. So my name's Katie Turman, and I have kind of the foundation of where I started is in social work. So I'm a licensed master in social work. And that led me into, I really just kind of wanted to do something different. And so I got an internship in a rehab kind of detox center. And that led to this whole life that I'm living now. I've since gotten a master's in addictions counseling and am a licensed addictions counselor on top of just being a master's social worker. So I've got lots of credentials and licensures I have to keep up. But I work in currently and for the past, like you said, like almost 20 years at what's called an IOP. So intensive outpatients doing primarily groups, but family work, individual work with the substance abuse disorder population. That's those are my people. I love them.
Yeah. Yeah. And you're incredible at what you do and how many people you've helped. And just so you guys know, I worked with Katie many years ago. I was I was a therapist there, but I was your partner for a little bit in the evening program. And
Yeah.
I mean, I learned so much from this woman, and I'm just forever grateful for knowing her and having her in my world. And every time I'm with her, it's fun and it's educational and we help people. So I'm really excited to have you on the show, Katie, and turn this episode into a Pocourse, because I think that this is such an incredible topic. And it's something that a lot of people who are just, whether you are seasoned or not as a clinician, it's always a great refresher or review to talk about addiction and treatment models. Because like you said, there's so much that comes out in the research and in the treatment that a lot of us therapists, we can only keep up with so much. So today we are going to cover about 3 objectives. And I'm going to go ahead and share what those objectives are. Number 1 is to define addiction and list the risk factors associated with addiction. Number 2 is to discuss and explain the biopsychosocial disease model and how treatment models can support this medical model. And the 3rd, summarize the biology of substance use disorder through education of the neurochemicals dopamine and oxytocin. So while I think that is fascinating, I thought it would be great if we just kind of start with just define addiction and list those risk factors, because a lot of people might need a little refresher on that. So what would you start with there?
So as any good therapist knows, one of the places we would go is to the DSM-5, right? Like we're going to head to the kind of the Bible of diagnostics. And in that, what I think is really cool, so in my career, as short as it's been, like that's made dramatic changes. So what I see now is that too many therapists are still, and even like for that matter, not just therapists, but like medical practices and everyone who comes in contact with this population, we're using old information and old data. Because DSM-4 separated chemical abuse and chemical dependence. And half of those had the disease and the other half didn't. And we're still operating under that old model and saying things like substance abuser and that kind of thing. Whereas in the past, I don't know, how long has DSM-5 been out? 5-6 years now, at least. It's actually substance use disorder. And we don't have an abuse criteria. We have mild, moderate, severe. So when we talk about substance use disorder, which is much easier called addiction for sure, when we talk about that, we have to remember to go to like current data. Way too often we're using old data. So currently we'd head to that DSM, we'd look at those 11 criteria. I think if we only had to have 2 of them, there's 2 hallmarks for me. Like if someone exhibits these behaviors, they're a huge warning sign. So one of those things would be, one of the criteria says use despite known consequences, right? And it words it bigger than that, but that's the gist of that. And so we have to think if someone is facing consequence after consequence after consequence, and their use continues despite all of that. And what's cool about that is it says known consequences. So this isn't like this person, I'm mad at them, right? Like they might not know that. This is like known consequences to their psychology, to their like physical person, their illnesses, their legal status, their job status. They are facing consequences, and using continues to be a priority in their life. So that's a hallmark of the disease. And I think it's important for what we're talking about later to say that that's a really important piece, is because that's such a biological component. We as a society judge that person to say they're making bad choices, right? And so we have all these consequences and think those consequences are going to change their choices. But because this is a biological disease, the consequences can't change their choices, right? And so for someone to have this, we really do have to say consequences are not effective because it's biology, And the other criteria I really think about as one of the hallmarks is it talks about the amount of time we spent getting it, using it, and getting over it. So if I use every New Year's Eve and don't think about it for the next 364 days, usually not a huge problem. But if I spend a lot of time getting it, thinking about it, getting over it, planning for it, if a lot of areas of my life are consumed with the mental energy of use, then that's usually a problem. So out of the 11, there's a lot of symptoms there, and well worth anybody looking up. But those are the 2 that really say, like, if if you see those symptoms, we are very, very likely dealing with substance use disorder.
Yeah. And I like that number 2 that you pointed out. I remember when you would present on that in group, you could just see the wheels kind of spinning, like, and a lot of people would try to justify use, they would try to justify, well, and it's fascinating that this is a disease. And, even the work that I do these days, I have a lot of people who tell me, oh, it's not a problem. Oh, I only, and they justify and they rationalize. And I always think of you and I think of group and I think, oh, you could probably use a little bit of Katie in your life. So
that's a huge compliment. Thank you.
It is. It's such a huge compliment. I mean, I know. So what would you say are risk factors associated with addiction? I mean, to me, that's kind of like, could be such a long list of what that could be, but can you throw some out that you hear a good bit?
Sure. I'm such a snarky person, you know this. Like my first gut instinct is to be like, are you American? Right? So studies have shown that like up to 90% of the US public is using substances. So we have a culture that actively promotes use. So can you think of a single show that doesn't have someone like unwinding with an alcoholic beverage at the end of the day, or socializing in those environments, or even like on streaming services, like weed use and things like that is just common, right? So yeah, are you American? Do you live in this public? Because that's a risk factor, because we've normalized use so much in our culture that it's almost countercultural to say, whether I have a problem or not, I'd rather leave substances out. That would be weird as an American. So huge, number one risk factor, do you live in this culture? Also, obviously, when we talk about anything like traumatic history, those things amplify. I don't know if you've had someone come speak on ACEs before, those adverse childhood experiences, but we know so much more now about how that affects the psyche, as a child, and you grow up. And because we have a culture that says use is so normal and so promoted, we also have a culture that says use is effective for coping. And so if I have something that I need to cope with, then I'm going to turn to substances very likely. So the more trauma, more stress, more whatever, the more I'm going to be looking for an out. The earlier someone uses, the higher likelihood they are to have a problem with their using. So, we know that frontal lobe part of the brain doesn't fully form until age 25. Use before that point increases problem, which is crazy to me because, like we said, we have a culture that totally excuses use in those college years. We call it normal. We say that, it's a growing rite of, all these things. You're almost supposed to do it. We excuse it. It's just young behavior. It's normalized. And yet we don't have a fully functioning frontal lobe during that time frame. Obviously, the earlier we start, the harder the problem. So when we've got middle schoolers using, that's a much bigger problem even than our college students using. Another risk factor, I would say, is obviously family history. Studies have shown that between a range of 50 to 85% of having substance use disorders is genetic. So it is hugely genetic. So if there's any family history, this isn't just mom and dad. This is, think like that next generation, think back to grandparents. And if it's in the family, there's a chance, up to 85% chance. So it's highly, highly genetic. Those are my big kind of go-tos of risk factors. So it kind of includes all of us, right?
Yeah. Well, it really does. And so it definitely makes me think about all of those things as where I am today in my life. But it also has me looking around at my kids and their peers. And I just wonder, like, knowing what we know about it, I would love to educate more people about addiction and the risk factors and the history and the biology of it, because I think you're so right. Like we excuse it and we normalize it. I mean, get on any social media platform and it's Wind Down Wednesday, or, there's a reason to be drinking, or I don't know. I just feel like I'm with you on that. So I'm excited to keep going. So, all right, let's talk about the biopsychosocial disease model. How would you frame that for somebody?
Yeah, all diseases are biopsychosocial. So I always, when I have family members or patients who are giving me like a little bit of pushback on, I don't think it's a disease, I think it's like moral failing or weak will or whatever, I always just equate things like I head straight to diabetes, cancer, heart disease, whatever. And I'm like, would you say this, think this, feel this about someone with another disease? The way that we describe all diseases as biopsychosocial is really taking three components and putting them into one word. So we take bio, meaning biology, there are physical symptoms, right? And then psycho, being psychology, there are mental, emotional symptoms. And then social, meaning there are environmental and familial symptoms. So you've got symptoms in all of those categories for something to be a disease. As opposed to like if I get the flu, right? We don't call it a disease. It affects my biology. It might affect my psychology in the sense of like, I'm a little sad that I can't get up and do these things I need to do. I had to cancel plans, whatever. But the system as a whole is not affected long term by me having the flu for a couple of days. Whereas a disease being chronic and long term, it does affect not just my physical symptoms, my psychological symptoms. It also affects the environment as a whole and is affected by all of those things as well. So it's kind of that dual relationship. I usually go into great detail. You see me do this in groups, but I go into great detail about how, like, let's look at socially acceptable diseases, right? So looking at the biopsychosocial of diabetes, cancer, heart disease, whatever, and just kind of pointing out that when we think of most diseases, we think of them as primarily biological. We think of these diseases as something like, well, I know about diabetes. Diabetes has it's insulin, it's blood sugar, it's happening in the pancreas. It can sometimes be progressive enough that it would cause blindness or need amputation due to neuropathy or whatever, all of these biological symptoms. But we don't often put ourselves in the shoes of that person and say, right, but how might you experience the world as a person with a chronic disease, right? Like, what does that feel like to have symptoms that set you apart from other people? What does that feel like at the holiday feast when everybody is like gorging themselves and you're having to check your blood sugar and you're having to monitor these physical symptoms? What does that feel like to possibly in certain types, like say, like, is there guilt here? Is there shame here? Do I feel angry about this? Like there's that whole grief process. And we don't often think about, but all diseases have that component of this person having to deal with the psychological impact for the long term of that disease as well. I want to head back to biology for a minute. There's a couple of hallmarks that fall into biology that certainly affect that psychosocial piece as well. All diseases are progressive, meaning they're not stagnant, they're not regressive. I don't well treat my diabetes and then like 2 years later, I don't have it anymore. I can treat it very well, but symptoms can still show back up and I will have to adjust the treatment because my disease has progressed, right? So all diseases are progressive. All diseases have a chronic until kind of death kind of component to them, meaning that it will continue to get worse. Not only that, but it is what we call primary illness. It can be the reason that I die, right? This is not a secondary death thing. This will be written on the death certificate potentially. And also, all diseases have a hereditary component, right? So when you go to your primary care doctor, I always think about like how interesting it is that some questions they're just asking about me, and they want to know my history and they want to know my stuff. But then there's that section of tell me about other people in your family. And that's only relevant because those are diseases and all diseases have a hereditary component. So my family history does matter. And like we said before, this has a hugely genetic component to it when we talk about substance use disorders. All of that, obviously, like we talked about with the social piece, all of that affects the family system. All of that affects the finances, which is a social thing. All of that affects how people treat us. There's kind of a continuum of some people are kind of all in. We sometimes call them enabling, depending on how all in they become. And they can kind of take over for our treatment and they can try to micromanage our treatment and they can, get super invested in every decision we make. And that, of course, affects our psychology because I don't want someone else to control every aspect of my life, no matter how well-meaning and no matter how loving they are. And then, too, the other end of that spectrum is some people get what I call kind of eggshelly, right? Like they walk on eggshells around me. They don't know how to treat me. So it's weird to say that like having a diagnosis could lose relationships, but it can. And not just stigmatized diseases like addiction, but people don't know how to handle uncomfortable things. And so being someone with a chronic illness means that people all around me have to face uncomfortable things. And it is what it is, right? So there's a huge social piece. It usually causes those who have any disease to kind of pull back and isolate, feel really set apart. And so all of these biopsychosocial things, they all kind of cycle together. We separate them into these three categories because it's helpful for us to see the big picture, but it's really also hard to separate those into those three categories because they all affect each other, right? We know our biology and our psychology are actually the same place. Like you can't separate your brain and your body. They are 100% fully connected. And yet the symptoms feel a little different in nature. Somehow we as a society don't promote psychological symptoms and treat them as important as we do our biological symptoms. Mm-hmm. That's not fair or true, but it's kind of how we view things as a society. One of the things I like to point out when I talk about this is people definitely buck up against the idea of addiction being a same disease, really just like diabetes and cancer and other diseases. They want there to be something different because we as a society have kind of pointed a finger at this population and said, y'all are bad and wrong. And really the only difference is that stigma. It is that social piece of the culture we live in, the environment we live in. We don't want it to be a disease. We, especially as Americans, we actually use a criminal model when it comes to this disease as opposed to a medical model. And if we actually bought into the science that's super obvious, like this isn't a debated topic. We are all very well aware that this is a biological disease. And yet, if society got on board with it being a biological disease, we would have to get rid of our criminal model and we would have to start using a medical model and a public health model in combination. So everything about our culture would have to change for us to really say, this is what it is, and the science is clear. So unfortunately.
Well, it's fascinating. It brings up a lot of questions and a lot of ideas, I guess. And, being that you are really in this world of addiction treatment, tell us about what treatment models are out there. And for those who are therapists who are listening and they want to know, like, what do I recommend? What do I do when I have someone in my office? And it's obvious, like we get to the point when we realize that we are dealing with addiction. What do we do next?
Yeah. Oh, that's a big,
it's a big question. I know.
I think it is a big question because there are a lot of avenues and I don't know that there's one right answer, right? Mm-hmm. I will say, so when you and I were talking about this a week or so ago, and I mentioned to you that what I see as a dangerous trend of we're moving in the direction of because one size doesn't fit all, we don't actually recommend anything other than like find your own path, right, which is not at all super helpful because could you imagine doing that with any other disease, right? Could you imagine working with someone who has cancer and them saying, I actually don't want radiation. Okay, cool. Let's try surgery. I actually don't want surgery. All right, cool. Let's do chemo, right? We wouldn't dictate and let them say like, well, here's what I'm comfortable with, right? So I get really nervous that we're moving in that direction where let them find their own path. I don't think that's helpful. And we wouldn't do that with any other disease. We're actually continuing that stigma when we're pretty loose about it. I always head back to that biopsychosocial model. And so all diseases are most effectively treated thoroughly, right? And I would say this is where this disease wins, right? Because in other diseases, they get primarily and almost sometimes solely biological treatment, right? They don't get their psychological symptoms addressed. They don't get the social stigma stuff addressed. They don't get that like family piece. They don't get the societal support necessarily. So this is actually where substance use disorders win because from the beginning of this, we've treated this more holistically. So if you look at the old AA approach, which I say old, I still think it is statistically, it's actually, there's more science that's come out recently, which I've been very excited about, that proves more and more that it is what works best for most. Historically, we just kind of use that anecdotally, like, no, most people do well with that environment. No, actually, now the science backs that up. Mm-hmm. People do better in that environment. So what I really like about the AA and the NA model, and really any of the mutual aid kind of 12-step groups, they do treat it biopsychosocially. So for example, the biology is they are abstinence-based. So meaning that, I always treat that biology piece for addiction is that often called an allergy, right? We have an abnormal reaction to substances, and we'll get into that more in a little bit, but it is an abnormal reaction to substances. And I will say, like, if I'm allergic to peanuts, how many peanuts am I allowed to have? With any other allergy, we are perfectly comfortable saying, no, you can't have any, right? We know that. And yet somehow with this disease, we think, well, don't use that substance or use that substance less. And sometimes I hear, and you've heard this too, like people get real fancy and real like kind of rationalizing with it. Like, well, I won't drink brown liquor, but I will drink clear liquor. Like somehow that changes the substance inside of it. So I love that AA and NA are abstinence-based because the biology says that we cannot safely use substances. So being an abstinence-based program, it's a good piece for that biological thing. So we just to kind of make a note, because MAT programs or medication-assisted treatment programs are very helpful. And I don't want to diminish that. But I want to be clear that the medications we use in MAT programs are the treatment of symptoms, not the treatment of the disease.
Right.
So they absolutely help with withdrawal. They absolutely help with urges. They absolutely help combat cravings. They absolutely do. But those are symptoms of the disease. They're not the disease itself. So we don't have any medical like intervention that comes and changes that brain chemistry.
I think that's really important to point out, because there's a similarity there too with people dealing with anxiety or depression. It's a similar concept that we treat the symptoms. We're not treating the disease. So keep that in mind, that because I worked with many people. They go, well, I'm taking this medication, I'm feeling better, and so I'm going to stop coming to counseling now. And I'm just like, whoa.
Yeah.
wait. So I think that's a really important thing to point out. And I'm glad that you brought that up. So that's a MAT model, right? That's what you said.
Yeah.
And an MAT model is probably going to be used in an IOP, like if needed,
depending
right?
Depending on the drug of abuse. Yeah.
Okay.
Not every drug out there has a MAT model that correlates with it.
Okay.
So mostly like your opiate users, sometimes alcohol users, but whereas like someone with cocaine or something like that doesn't really have an MAT model because there isn't a medication that treats that as much. The kind of quick go-to I always say is pills and skills, which is true for every disease under the sun, right? So if I have high blood pressure, I'm going to take a medication for that. But if I don't also adjust my lifestyle or diet, that medication is less effective, right? So this isn't just a, addiction thing where we say pills and skills, or like you said, a mental health thing. This is just a health and wellness thing that if I have something that I need medication for, I better also have a lifestyle that supports that medication. So pills and skills always.
I'm going to remember that. I haven't heard you say that one. Write that down. I wrote it down. I love it. That's a great way to frame it with clients or patients. Sure, you can take the pill, but you have the skill to modify your lifestyle or to change your lifestyle. So the symptoms aren't as severe and you have a new way of being in this world. I love it. Okay. All right, great.
Yeah. So that's that like biological piece of treatment. Then we have the psychosocial stuff. And if the biological piece primarily kind of revolves around abstinence, then we definitely have to look at the psychosocial piece, because how long am I likely to stay abstinent when my world is in turmoil and when I'm grieving and when I don't know what to do with everything else that's happening around me? So I don't even think that abstinence has to come first. I think we have to treat it holistically. We have to treat it together. And I think too many therapists, too many family members, too many just people in society assume that if you can't get abstinent, then you can't do anything else. And I think those things have to be worked on together. So doesn't it make sense that if I go, if I'm living in an environment where use is actively promoted and there's a lot of chaos and there's a lot of drama, then I shouldn't be shamed for using, right? When I'm trying to work on not using, because it's a symptom of the disease. So we don't tell any other person with any other disease, we're not like, we've been treating this thing for a week and you still have symptoms. Right? We don't shame them in any other disease. We know that the treatment process is actually, your symptoms will reduce as we treat this thing more. I think using and substance use disorders and all, that's all the same. Using is one symptom of the disease. And so possibly it's not going to be the first symptom to drop off the list. So we've got to look at the psychosocial piece. We can't just say, if you're not abstinent, we can't do anything else. So psychologically, AA and NA use the 12 steps. And what I love about them, if I'll give a quick overview of the 12 steps for people that aren't very familiar with, we all know there's 12. We know they're super popular. But the gist of them is 1, 2, and 3. Steps 1, 2, and 3 are really about how do I cope with the next 5 seconds of my life, right? What do I do in the situation I'm in right now? How do I handle this that's right in front of me? That's steps 1, 2, and 3. And that's where we have to start. Like, I can't handle the big stuff yet. I've just got to handle the next moment in front of me. Mm-hmm. And then 4 through 9 are often called the action steps. That's when I have a little bit of stability under my feet. And so I start looking backward and I start saying, like, what in that wreckage that I've created, what can I deal with? Mm-hmm. And I start systematically through these steps, 4 through 9, I start systematically handling my own stuff, the stuff that I caused, the stuff that happened to me, that wreckage of past, whether I was a victim to it or whether I was a participant in it. All of that has to be handled systematically, because I cannot have symptom-free. I cannot have contentment. I cannot have a lack of use if I still have all of that weight of all of that past weighing me down. So it's really about working through that process of saying, little by little, piece by piece, I can handle the moment. I'm working 1, 2, and 3 consistently. Now I'm going to start handling that other stuff. And then we get to 10, 11, and 12, and those are our maintenance steps. 10, 11, and 12, if we do those things, they all kind of speak about how do I keep that wreckage from becoming like current wreckage, right? How do I make sure that I don't have years of resentment piled up against me? I want to handle things day to day, moment to moment. Little things while they're little. Don't let anything become a mountain. Handle it all while it's a molehill. And then there's also a huge piece of service. I'm going to give back. I'm going to be an active participant in my family and my community and my fellowship. I think I would be really sad if we ever got away from that model, right? Because there's such beauty to me in that systematic process. And when you think of any other therapeutic model, it all kind of does that, right? So a lot of what we do as therapists is that process. But how wonderful that there's a system in the world where completely for free, you can go into the rooms of AA and NA and have someone help walk you through that process. Because not everybody has resources to get a private therapist to do years of work with them. And not everybody has what if you're moving around or if you travel, all these things. It is beautiful to me that a homeless person can walk off the street and no one is going to judge them in that place. You're not asking for your insurance card. We're not asking for any of, we don't have to have ID. You don't have to be a legal citizen here. You don't have to have anything. Literally, the third tradition says the only requirement is a desire to stop using, which I think is so inclusive and beautiful. And I don't want us to veer away from that. And noticing, just because it's been around since the 1930s, I don't want us to say that's old. It's actually more and more science is supporting what they did all those years ago. And then that social piece, because we have that huge stigma in our society, because the rest of the world is against us, they don't understand us. It actually is really helpful and really, peacemaking is the only word that comes to mind, but serene. And to be able to walk into a room and all I have to do is say, I'm Katie and I'm an alcoholic. I'm Katie and I'm an addict. And I am welcomed and I am loved and I am supported. And the stigma doesn't exist there. And there's a peace and a freedom that comes from knowing I'm a part of a fellowship of people just like me. Right. Because I think one of the things that we believe when we're sick is that I'm the only one, right? Mm-hmm. And that keeps us isolated and that keeps us alone. And when that's the case, when we are isolated and alone, we cannot get well. We cannot get help because we don't think there's anyone out there who can help us. No one understands us. And to walk into a room full of people literally anywhere in the world at any time of day, I can walk into a room and be 100% understood. Right? Like, that's beautiful to me. So what works best for most is still that model. The AA and NA, that 12-step model, because it does treat the biopsychosocial piece so beautifully and so effectively and so accessibly to everyone. So you might say, like, as a therapist, you might be like, I don't actually understand addiction all that well. And I don't want to refer this person out to a different therapist necessarily because we have a lot of rapport here and we're working on some really important things. Well, great. Refer them to the free services of AA and NA in your community. And it doesn't necessarily compete with your work as a therapist at all. Now, of course, they might also need an MAT program for a period of time. They might need detox. They might need an IOP program like I do. They might even need 30 days in a residential program. But as you know, when someone comes into a program like that, we always refer them back to their regular therapist. So we don't want to compete with that work because sometimes a therapist is really, really helpful, especially in that kind of 4 through 9 step phase where someone is having to work on that stuff. You know, depending on their past, depending on what they've walked through, that really does require a professional.
Yeah.
And so we don't want to interrupt that therapeutic relationship, but we definitely want to say that there's other resources out there that can supplement and can help. I think too often therapists think, I don't understand this, so I kind of get hands off about it. They essentially, unintentionally, they perpetuate the stigma that this is hard and different and out of my wheelhouse and uncomfortable. And so I'm just going to, the therapists get kind of eggshelly, right? The therapists get a little, I don't know what to do.
Yeah. And I think that's really important to say that out loud and to have folks listening, you know, it's okay to feel that way because I think so many people do. Yeah. That's why it's always wonderful to have a resource or a connection at an IOP or someone that you know that you can consult with. So I think that's great. And I get asked to consult a good bit at my work because they know that I have a background in it. And so can you speak a little bit to that therapist out there that I think this will be helpful? Like the person listening who is in private practice maybe has a couple of patients, clients, and they recognize there's addiction issues going on. So instead of being eggshelly, what do you recommend for that therapist to kind of be a little bit more challenging with the patient? What are the boundaries for helping that patient with addiction? Like, do you understand what I'm trying to say? I mean,
I do. Well, I have one follow-up question. So are we saying that the therapist thinks there's a problem and the patient doesn't necessarily, or the patient is saying, I think there's a problem and the therapist doesn't know what to do about it? Or both?
Let's do both. Well, if you can do both, because I've been in both of those situations. And the second one is a little bit easier for me because I know what works. But let's say I'm the therapist and I'm thinking something's going on and I'm not quite sure what to do next, you know?
Yeah.
Maybe that.
I honestly, so this might be oversimplifying, but I think the first place to go is certainly whatever your therapeutic style is, use it. You know, I tend to be a little front door, right? I'm a little confrontive. You're not going to wonder where you stand.
Just a little. But that's okay because our styles are very different, you know, and I love that about you. I learned a lot from you in the beauty of being challenging and confrontational, but with love and empathy. So I'm not saying that you don't have those because you definitely do. I don't think you would be in this work, but I love that about you. So talk about that. I think that's helpful.
Yeah. So I think you can do it from whatever your strength is. I can't speak as much to what it would be like to subtly kind of work your way in there, but I always really like kind of going on the experience with somebody. You know, I'm the kind of therapist that says, we are just two humans in this world together. And there's not a hierarchy in therapist-patient relationship. There's not one of us is better than the other or more knowledgeable than the other. Like you are the expert on your life experience. And I'm getting the privilege to walk alongside you during a piece of this journey. And we're just two humans who are doing that work together. That's kind of my style in things. And I think I work really hard to destigmatize, you know, so that is a style that I think works for me because I don't want anyone to ever think that I'm looking down on any of the things they're bringing to me. So being curious about things, right? Like asking a lot of questions and saying, hey, what would it be like if we took a week off of using? Or when you tell me that you smoke weed every morning before you can even go to work, like, tell me about what are the thoughts that come before that? What are the thoughts, you know, kind of really, there's a soft way to challenge someone. It just really says like, hey, I noticed that this might not be helpful for you. What do you think? What if we explored that? Can we spend a little time here in therapy talking about that? And honestly, gauging their reaction, right? So if they get really defensive, this is something they've thought about. One of the DSM criteria, the very first, in fact, DSM criteria, says that it has the word in it, it has intention, which I love. It says that we try to adjust the time and amounts of our using. We have an intention to do that. And so intention already tells me that someone who has a problem kind of has an inkling inside of them that they know it's a problem. And so they're not yet at a place, if you're confronting them and they're getting defensive, they're not yet at a place where they want to talk about, I have an intention, right? They don't yet want to bring that inkling into consciousness. And they're getting really upset that you would like them to. Yeah. So gauging defensiveness when you confront someone, the same way we do when we confront them on anything else, right? As therapists, we do have to gently kind of poke at things every now and then, and we do gauge their reaction based on how serious an issue it is. This is no different. Gauge the reaction. And even I think then that reaction becomes part of grist for the mill for therapy, right? So we then say like, wow, you were really defensive about that. This is clearly something that really matters to you. I think that's worth bringing into therapy. It's clearly important to you. You know, if it's worth getting defensive about, it's something that really speaks to what's going on inside of you. It depends on, like, if a person is showing up intoxicated, if a person is showing up under the influence, we all know, like, we cannot do good therapy with that person. And so I think boundaries are really important, right? Like, you can't show up under the influence and us do any work. It's fraudulent for me to bill you for that time, you know?
Right.
So definitely we are absolutely allowed to have boundaries around using. We can say things like, on the days before you come here, you are different when you have used. I would really appreciate you not even using in the 24 hours before coming to therapy. And then obviously the lines get drawn more from there. If you need to, it's perfectly fine to refer someone to a higher level of care. If once a week outpatient or every other week outpatient is insufficient, then a higher level of care is warranted. That's where your IOPs come in. I think too often we get scared of, like, I don't know how to handle this. And I hear this from family members all the time. They immediately assume this person has a problem. I want them to go away for 30 days. Right? And that's the first reaction. No, they need it. They really have a problem. They need to go away for 30 days. I'm like, well, one, have you looked into the finances of that? Right? Like, before you make the snap decision, are you willing to cash in your retirement sometimes?
Right.
But also, we don't, in any other area of life, we don't start at the most restrictive level of care. You know, we always start at the least restrictive level of care, and we see if it's effective. If we have discovered through therapy that once a week therapy is not a restrictive enough level of care, then we don't move it all the way up to residential. We move it to an IOP, you know, which is 3 to 5 days a week of therapy. And then we move it up from there. So I always tell family members and therapists too, that if you get them into a IOP, at least level of care, or honestly, even AA and NA, or working with a peer support person, all of those people have been around this enough to be able to, essentially, they'll handle the confrontation on, do we need an even higher level of care? You know, like when someone is ineffective in an IOP level of care, we're not relying on their family members to yell them into residential treatment. We are the therapists who are saying, hey, listen, we've tried this. We've done this level of care. Your symptoms are not reducing. This isn't a shameful thing. This is just how we medically treat things, right? We don't treat stage 5 or stage 3 cancer with stage 2 medications, right? We would do the same with this. We don't treat stage 3 progression with stage 2 treatment. But I think getting people who are knowledgeable involved, like you said, I really love that. Just kind of always have someone in your back pocket, right? Like a therapist in the community who does do this stuff, so you can say, help me out, get some other feedback about that. If the patient's coming and saying, I think I have a problem, I think the reaction is pretty similar, right? Mm-hmm. I get kind of, let's walk alongside this together. Okay. Let's be curious together. How about you try to get us some meetings? Let's see what that's like. Let's hear in our session, let's look up AA and NA meetings that might be in your area, right? Let's try them out. Let's see how they're a good fit. Let's try a couple of different ones. Let's not just go to the same one and count it out. let's get curious about this together. Let's look into things together. Let's supporting that person. And if they're coming to you and saying like, it's really bad and you discover like they need detox, obviously don't take your time and just say like, let's look at AA together. Like if they're going to die in withdrawal, please get them medical help.
Yeah.
But I think that's a different assessment that you as a therapist would make.
Yeah. I do want to like kind of point out that I wish it was that linear and that direct. So many of the times in private practice, it's not going to look like that at all. It's going to be, they come, you recognize they have a problem, you start to talk about it, they're in denial about it, it's not that bad, but it's getting worse. They're social or the consequences are picking up. And you as a therapist are going, this is obviously a problem. And, you recognize that, but your client or patient isn't quite ready to take that step to do different. And so I want to recognize like, that's very common,
Very.
It's rare that it's so linear, that it's 2 sessions in and you're referring them to an IOP. And so those listening who might be going, whoa, that's not my experience. Well, I think your experience is probably, that's been my experience outside of IOP. It's rare that it's linear like that. Sometimes it's 2 steps forward, 15 back, and then 3 months later, so I think it's important to kind of like just put that out there. It's rare.
I would just say like, don't shy away from keeping the conversation open. Right. If it becomes an obstacle to doing good therapy, then I think we do ethically have to like set boundaries somewhere. And plenty of patients coming into an IOP level of care because the therapists that they've bonded with have said, listen, I cannot work with you anymore until you've completed an IOP. And they value that relationship. And so they seek a higher treatment. So I have the utmost respect for the therapists in the community who are willing to draw those lines and set those boundaries, because I think we do a disservice when we just don't want to touch it. Keep it a part of the conversation, even if it is 2 steps forward, 15 steps back. Because if it's obvious enough for you to notice, like, this is clearly an obstacle here, then it's your job, I think, to keep it in the awareness, right? We're not going to support them hiding things from themselves. That's not what therapists do. So
that's right. Well, I hope not.
Right.
That's not what we're doing.
Right.
Okay. So is there anything else you want to talk about when it comes to treatment models? Maybe it's important to kind of touch on what else is out there that, is been shown research-wise to be effective, just so folks have some other better.
That's actually where we get into muddier waters, is that research part of things. There's a lot out there that isn't researched. And I think people head to it because I'll use kind of AA lingo. It's an easier, softer way. Sometimes because something has been around for a long time, we immediately assume that it's no longer relevant. And there's newer models, and some I think are helpful and some I think are not. And I'm just going to present them and try to not have my bias show through what I'm saying. But there are people who go to what's called Celebrate Recovery meetings, and Celebrate Recovery is very similar to AA in it's like it has a 12-step model, but those 12 steps are based on Bible verses, and it is a Christian faith-based place. So churches usually hold them. They're usually a couple kind of scattered throughout any town. They are through a ministry that was like Rick Warren, do you know of like Purpose Driven Life? So he's the one who kind of like spearheaded starting a lot of this movement. And so churches usually put it on as a kind of community outreach process, I guess. And then there's Smart Recovery, which is like CBT. So it's doing like a kind of cognitive behavioral, more of a education-based and, systematic, and let's look at your thought processes and things like that. But instead of doing that in an IOP or with a therapist, you're doing it in a Smart Recovery meeting. And they are, I don't know, our town probably has 5, 6 of them. So less than Celebrate Recovery as far as how prevalent they are, at least in our part of the country, but have been around for a while. And, that certainly we know, like we said, the psychosocial piece is a huge part of this disease. So looking at those coping skills and looking at that stuff is helpful. Some people try just a kind of public health model, which isn't really a treatment model in and of itself. It's just a harm reduction. So I'll try to do this less. I will do this in safe spaces. I will, and the community often supports things like this through like clean needle programs and safe injection sites and things like that. Test strips that make sure there's not fentanyl in your opiates or whatever.
Gotcha.
So those kind of things are a model that I think our communities put on, but are not so much like a place you go and kind of work a process of recovery per se. I'm trying to think, there's so many other options. So all recovery meetings, which are for really, I mean, it's exactly what it sounds like. All recovery, whatever the drug, whatever the situation, it's just a place for recovery processes. People come together. These are mostly called like mutual aid support groups, in the sense of there is not a professional present. You don't have a leader. Everyone's equal in that community. And for me, I think anything is effective as long as it meets the biopsychosocial model. So a lot of these things can be, you kind of can have like patient preference on which of these do they prefer, as long as it meets those three criteria of this treats this biologically, this treats this psychologically, and this treats this socially. That matters.
Gotcha.
So, I always head back to the science when it comes to that. The downside is a lot of those things are not like researched. They're effective. People are getting long-term recovery through those programs. There isn't a lot of science. Like I said, like AA and NA have just now gotten the science that's backed them up, and they've been around since the 1930s. So it'll be a while till we have a lot of science on all these issues. But if those three components are met through the program, then it can absolutely be effective in treatment.
Okay. Well, that's really helpful. Thank you for going over those and reviewing the different models. That was great. So let's pivot a little bit and talk about neurochemicals, dopamine and oxytocin. This is like your thing. You love it.
I know.
Give me what you got.
I dig into that biology quite a bit. So when we say that this is a biological disease, this is where some people kind of give us the pushback. Like they know it's psychosocial. They don't really understand the biology. Or if they do, like even like I will pose this question to patients who fully say like, yes, it's a disease and I have it. And I'm like, great. What are the biological symptoms? And they got nothing. Right? They have no idea. So at the very most, I get things like tolerance and withdrawal, right? Like those are clearly biological hallmarks, that tolerance being either one of two things. Tolerance meaning either I use more to get the same effect, or I use the same amount with less effect. So I always equate this with like the morning cup of coffee. In the beginning of coffee drinking, your first cup of coffee was just like, you're already gotten your shower, you're already ready for your day, and you drink your cup of coffee. And it's just a little bit of that caffeine boost to kind of get you mentally awake. But eventually you are the kind of person that like stumbles to the coffee pot first thing and has to have that coffee before you feel human. Not every person all of a sudden becomes like a 10 coffee drink person. Some people are just one coffee drink, but that one thing of coffee has less effect than it did in the beginning. And some people drink more coffee to get the same effect. Some people just keep that one cup, but clearly, it's more necessary because I'm stumbling on my way to the coffee pot. So that's how I describe tolerance, as either one or two, either one of those things being present mean a person has tolerance. It really just means that I'm using it with enough regularity that my body's used to it. That's really what tolerance means. Okay. Withdrawal being the flip side of that coin. If I have tolerance, I'm going to have withdrawal.
Okay.
So I do think this is where some therapists, it's helpful for people to say like, to not shy away from what are you using and how often and how much. Those questions are important questions. Yeah. They definitely do dictate, do you need medical intervention or not? The presence of use in and of itself does not require medical detox. It really does matter what you're using and how much you're using it, because some drugs can kill you in withdrawal. So we don't want to just tell someone, I really caution therapists, I'm like, don't just say stop drinking. If you don't know how much that person is drinking and how often they're drinking, you do not know the withdrawal that they might face, and it could be deadly. So if you're not sure, definitely don't say just quit drinking. Ask some questions first. So tolerance and withdrawal are obvious biological symptoms, but those are not the symptoms that are there in that hereditary component, right? Both of those things require that I'm using regularly before that symptom presents itself. However, this being a biological disease, and a large majority of those who have it have a family history, there are physical symptoms present before this person ever uses a substance, okay? And there's two parts of the body that are affected by that. The liver, usually there's an insufficient quality and quantity of enzymes that changes the acetone message when alcohol goes into that liver to be processed. And the sugar and the water and the acetaldehyde send, they do their sorting process. The actual message to the brain is different. So a normal reaction when someone drinks a beverage. So the liver only comes into place when someone is orally ingesting something, right? So this would be like pills and alcohol. If I've orally ingested it, a normal reaction is for the acetaldehyde to tell my brain, this is a poison, right? Mm-hmm. And so my brain is going to start saying, oh, I need to tell Katie that she's ingested a poison. And the way it does that is it makes me like flurry and blurry and stumbly, and it gives me these physical reactions to let me know that what I ingested was not safe for my body. And that's a normal reaction. Now, we have normalized that reaction in our society. We have promoted it. We've said it's perfectly fine. We knew we were going to get it, but it's still our body's warning system. The downside of that warning system is that those who have substance use disorder, the acetaldehyde level, because the enzymes are different, the acetaldehyde level is different, the message to the brain is different. And it's kind of like the message gets reversed. So instead of warning system, the message actually becomes more, right? Mm-hmm. If one felt good, two will feel better. And when my brain tells me that I should ingest more, I don't often ignore my brain. So we have another one and the message is more. And we have another one and the message is more. And it keeps going and it keeps going. I love how AA has a slogan that says, one is too many and 1,000 is never enough. Mm-hmm. And I think that's cute, but it's actually biology, right? One is too many, 1,000 will never be enough because of that acetaldehyde message that keeps going to be sent over and over, and it's never going to change its message. This is literally the allergy, right? I have an abnormal reaction. A normal reaction is a warning system, and I don't get a warning system. So what we've shown, there's a study that was done, and this was decades ago. The study was done that showed those who have a family history on their very first use. Okay. So this isn't the use that has like, I'm 10 years into using and I've earned this kind of symptom. This is very first use. Those who have a family history have a weaker warning system. So that alert that we're all getting is less. They have less nausea, less body sway, all of that. And they actually have a greater sense of euphoria. So they have less bad, more good from the very first use. And then we come to them and we're like, hey, why do you have a problem? You're not making good choices. And it's their biology that's telling them, we found a solution, right? What I'm doing is more effective in me than it is in anyone else, right? So that's just the liver, right? We haven't even gotten to the brain yet. Yeah. What it's doing, though, that euphoria system is that dopamine piece. And with the brain, so most people, at least, I don't know if we really think this, but we treat addicts like the disease lives in the frontal lobe. Like the disease lives in the place that makes decisions and decides what's right and wrong and good and bad. Mm-hmm. That's where we treat addicts. That's why we have a criminal model to treating. Treating's a loose term when we talk about our criminal model because they're not getting treatment. They're getting punishment because we think they made bad choices. They deserve punishment. Right. And so we treat addicts like they have a problem in their frontal lobe. And actually the disease lives in the midbrain, which is part of that limbic system, which is where dopamine likes to release. And so that limbic system is our, we think of it like our pleasure center, but it's really our reward memory center. So when we need a reward, dopamine releases into our limbic system. And that could be from a lot of things, right? Like this song I like, this interaction with this friend, whatever it is, right? We get dopamine from that. And so dopamine actually says, this is important. This is a reward. Remember this. Do it again when you want this reward again. And so it's kind of that memory reward center. Well, in that limbic system, there's a part of that's called the midbrain. And the midbrain tells everybody 3 messages. And these messages are really important to all humans, that they are pleasurable because they keep us alive. So if they weren't pleasurable, we probably wouldn't prioritize them. We wouldn't do them very often. And therefore we would not live. So everybody gets these three messages: eat, kill, procreate. And, eating, obviously, I don't know if you're like me, but the day gets really busy, right? And so if there was zero reward from food, if like ingesting food was equivalent in my life to like cleaning the bathroom, right? Like something I don't want to do, but it's on the to-do list, right? If food were like that, then I would go days deprioritizing it. I would push it to the back burner. I would like, I'll get to it sometime. All these other things are more important. And so we know that food has to have pleasure to it so that we prioritize it. Protection is that same thing. Often it was kind of kill back in the day. Your food had to have a face and you had to go hunt it down. But it also is our protection sense of I'm willing to fight to keep me safe and to keep my children safe and keep what's mine safe. So that eat, protection, and then procreation, we know that has to have pleasure and it keeps us going as a species, right? And so everybody gets those messages, but actually those with substance use disorder have a fourth message that's prioritized even higher than those other three messages. So they get eat, kill, procreate, but they also, even more importantly than those things, is the using. So dear sweet Nancy Reagan and her Just Say No campaign, which was not a huge success, and then what came after it, like DARE and Scared Straight and all these other things, all of those programs work directly talking to that frontal lobe. Every single one of them is saying, you're not making great choices. If we showed you information, if we showed you what jails look like, if we showed you and talked to you about these things, you would make different choices. Well, like I said, we live in America and Americans are using. So no, we're actually not getting that message from our society. And even if we did, that's not where our disease lives. The disease lives in that midbrain. And so what actually happens is that the midbrain, in order to kind of take over, it shoots a chemical, it overrides the frontal lobe, and now the decisions are being made by the midbrain. So the frontal lobe doesn't even get a say, like the rights and the wrongs. We know this, right? So remember we talked about the DSM criteria that says we use despite known consequences. This is how I know that's a biological symptom, because my frontal lobe is saying, I know my spouse said they'll leave me. My frontal lobe is saying, I know I'll lose my job if I show up this way again. My frontal lobe knows all of those things, but my midbrain has chemically overridden all of that and using as priority. And so even though I know the consequences, I'm continuing to use, not because I don't really understand those consequences, but because I fully understand them and that part of my brain is not making my decisions. This is how I know that shame is such a huge piece with substance use disorders, because I do know, right? My frontal lobe is fully intact. I am well aware of the consequences, and yet I use anyway. And so shame is a huge piece, not because our frontal lobe is broken, but because it's intact. It's just that midbrain that's making the choice. And so that's why I think it's really helpful for people to get involved in a treatment that includes that fellowship of like-minded people, because our friends and our family and our well-meaning loved ones are going to talk directly to our frontal lobe, and they're going to remind us of consequences, and they're going to remind us of the last time we did this. And we do not need any more opportunities for shame. We, in fact, need someone who knows how to talk to the midbrain. We need someone who's going to say, let me talk to you the way that I needed to be talked to, because I too have that midbrain that talks like that. Right. And so that piece is such an important piece. So that's that dopamine thing. And what I really love about, so kind of bring in some like treatment to dopamine, I really love how AA does a really good job about this. And when I say AA, I use that term to kind of just mean mutual aid support groups, right? Like those programs that biopsychosocially treat this disease well. And it's just shorter for me to say AA and NA than it is for me to list all of them. But really, as long as it's meeting those three criteria, then good. Because we come in so shameful, and it's really great when someone like, I walk in and I expected it to be a room full of people who are like miserable, right? And their lives are like mine, and they're just in ruins and whatever. But they're not. They're laughing, they're shaking hands, they're talking to each other, they're cutting jokes, they have the same sense of humor that I have, like all these things. And dopamine starts releasing for the first time in kind of a while, maybe on a natural level of just, oh, okay, this is a safe place and I can release dopamine here, which is really important. Because what happens is drugs and alcohol actually spike dopamine. So when we think biologically, think like your temperature. when you are well, you have a kind of normal for you temperature, and it's somewhere in the like 97, 98 range, sometimes low 99s. You have a normal for you temperature range. But when you are sick, your temperature set point resets and you might have 101, 102. And when you're well, it goes back down to the normal for you temperature range. So your temperature set point tells you wellness or sickness. Well, your hedonic set point says the same thing, wellness or sickness, when it comes to your dopamine. So with that, it's looking at saying like drugs and alcohol are spiking dopamine higher than normal. So you've got this range of normal in your dopamine, and it's things like, I liked that song. This is a funny show. I laughed at that joke or whatever. And dopamine is releasing with memories and scents and smells and sounds and all these other things. And they're just kind of, releasing in that normal range. But then we use. And when we use substances, we are spiked outside of that normal range. And if we spike outside of that normal range regularly, what actually happens is our hedonic set point does like our temperature set point, and it resets to a higher level. And now I can no longer feel the dopamine releases of those normal life pleasurable activities. I can only feel dopamine that is spiked into this new range of normal, this higher than normal setting that really only drugs and alcohol can touch. So I only feel pleasure when I'm using. And then people come along and they're like, just say no, right? That's not effective because I feel nothing when I just say no. So we've got that. And unfortunately, unlike a temperature that can reset in an hour, the hedonic set point takes much, much longer. And so someone will go through a period of what's called anhedonia. When I'm not spiking dopamine into that hedonic range, I will feel anhedonic, the absence of pleasure. And it's kind of like I have to starve my dopamine system. I still need to release it down there at the bottom in those normal pleasurable things like meetings and, music I like and people that are supportive. Still need to do all those things, but I won't feel it. And sometimes we perceive that I can't feel the pleasure as it's not pleasurable, which is not true. What's really happening is I have a hedonic set point that only feels spikes, and I need to starve it. Because if I starve that hedonic set point from spikes, it will reset back and I will feel those pleasurable things at that normal kind of dopamine release level again. So it's really important that we, I think, know, this isn't just emotional grief. This is actual biological anhedonia, right? No, so we know that someone's going to like be sad and blue and feel set apart and all these other things. But even more than that, they are unable to feel pleasure, even if they're doing pleasurable things. So that anhedonia period is really important, I think. And I think continuing to go around safe places and safe people during that time is important so that when I can feel dopamine, I know that it's in a good and safe place.
You put that so well. And I can think back to times when I was working with you and when that kind of set in for some people, you could almost you could see it on their faces and they were just like, I don't feel anything right now. And you were like, that's normal. That's okay. We'll come back. This is part of the process.
So oxytocin is where the new science comes in because we've known about dopamine for a while now.
Yeah.
And the new science comes in with oxytocin. And I think it solidifies those same treatment paths that we've done all along. So oxytocin, I think of it as almost in the way that we treat it, it's almost the reverse of dopamine. Okay, so with dopamine, we have spikes, and with oxytocin, we actually have a deficit. Oxytocin is, like the history of it is, a lot of people assumed that oxytocin was only or primarily released when someone was like mother and child, right? Like in the birth process, in the nursing, breastfeeding process, like that's when oxytocin kind of was released and people thought it was really isolated to that environment. And we've learned a lot more about it recently in that oxytocin is actually much more closely linked. It's kind of our trust hormone. So when I am trusting, when I'm around someone trustworthy, when I'm doing trustworthy things, I release oxytocin. So people that were given oxytocin, like extra shots of oxytocin, is actually kind of like a nasal spray. It's how they do it in the science. But they made eye contact more. They were more generous. They spent more time like touching people. So there's a lot of science that says oxytocin really is more closely linked to trust. And when I first heard about oxytocin, I didn't equate it with addiction at all, or it wasn't being equated with addiction at all. And my brain, of course, went straight to like, all of my patients need trust, right? That's the one family thing I do over and over and over again is family members like, I don't trust him. And the patient's like, I deserve trust, right? And so when I think of trust, I was like, okay, how can I start putting these two things together? How do I get family members to kind of tap into oxytocin when they're with this person in new recovery? How do I kind of manipulate that process, or how can I create that? And so I had to learn a lot about oxytocin. And what's cool about it that I learned is one of the things that's right there with that midbrain is our amygdala, right? And the amygdala is kind of like pain memory, hurt memory, okay? So it's still in that memory center, but it is the warning system. So let's say 2 years ago, I got into a car accident driving on ice. Then every time I have to drive on ice, my amygdala is going to send me these fear memories of like, be careful, be cautious. You might not want to do this, right? And sometimes that becomes panic. Sometimes that becomes a lot of things depending on that fear memory, right? So our amygdala is what's yelling at us and talking to us, and it's shooting out all these, and it kind of deals with our cortisol and our adrenaline and all these other things. So there's a lot of reasons why my amygdala might be yelling at me. Your amygdala is the number one. There are receptors for oxytocin everywhere. Your amygdala is your number one receptor. Okay. And if you really think about it, that makes perfect sense, because what overcomes fear is trust, right? So if I am releasing a lot of fear hormones, and if I am in a really anxious place, the thing that will soothe that the most is trust, is safety, is calm, right? And so the amygdala, which is screaming out fear memory, is best soothed by oxytocin. And oxytocin, if we're using substances, we actually, it's almost like it blocks my oxytocin abilities. I can't release oxytocin if I'm using substances. And that's not if I am abusing substances, if I'm addicted to substances, if I'm using substances. So for all of us Americans out there, the 90% who use however casually, just know that it is blocking your oxytocin sometimes when you're using. So if I'm using chronically, if I'm using a ton, if I'm using often and regularly, then that much less oxytocin is getting reduced. So I'm interacting with the world, and the world is not a trusting place, right? And the more I use, the less trusting the world becomes, and the less I can receive any of that, and the less oxytocin I release. So that being the case, what we know is that we're coming into recovery and we don't trust people. And they're telling me things like, hey, you should go to this meeting full of strangers, right? And you should get a stranger to sponsor you. And you should work with these people and tell them your deep, dark fears. And I don't want to do any of that because my amygdala is screaming at me and I've got no oxytocin. And I go home to my friends and family and they don't have any oxytocin because they don't trust me at all. And so we're all kind of in a depleted state, whereas dopamine is in spike state, oxytocin is in depleted state. What I think the beauty of 12-step recovery or mutual aid support groups is I go to this place and people look me in the eye and they shake my hand and they give me their phone number. They trust me implicitly because I showed up in the room, right? And they do all these things that release oxytocin. They look me in the eye, releasing oxytocin. They shake my hand or give me a hug, releasing oxytocin. They show me trust by handing me like their personal information, releasing oxytocin. And so, you and I both know that when we worked with patients and they'd come back after their very first meeting ever, and they would have this glow about them. And it kind of was an oxytocin glow. We just didn't know to recognize it at the time because they had been so depleted for so long. And they don't get that at home still, right? Like with 5 minutes clean, your family and friends are not trusting you around their medicine cabinets and their purses. Everyone else in the world is still treating you with that social stigma. You are a pariah. You are a bad person. You're making bad choices. The consequences are everywhere. And you walk into this safe space and you are not only welcomed, but you are accepted and loved and supported, eye contact, physical touch, all these things. Oxytocin is releasing. So when I hear patients who say things like, I want to do this on my own, I get very nervous, because if biopsychosocial treatment is not involved, and if we're not working on oxytocin and dopamine, then we're not going to be successful, right? Those pieces have to be in play before we can really say, I'm doing what I need to do to treat this disease. And oxytocin and dopamine really are part of that biological treatment. So I love, historically, it's just been abstinence. Most recently, it's also been MAT programs. But we have to look at dopamine. We have to make sure we're starving it. We have to look at oxytocin. We have to make sure we're putting people in places where they can be trusting and be trusted, so that we can kind of work on both of those things and bring that back to midline. So
that's some incredible information. It just blows me away how much is out there now, that when I was at the treatment center with you back in, 10 years ago or something, more than that. It's just incredible, the research that's come out. And I'm just so grateful. Thank you for sharing all of your wisdom and all of your knowledge. I know this is going to help a lot of therapists out there. And then I know there are folks who are listening that aren't therapists, and they might be wondering, if they are dealing with substance use or addiction, do they have this disorder or this disease? And I really feel like you've explained it so well.
Well, thank you.
Yeah. And so I'm going to put all the resources in the show notes. And is there anything else you want to share before we end the Pocourse?
Well, just to say thank you. This is a great honor for me, but also if there's anything I could just send out into the world, it would be destigmatizing this disease, treating people who are hurting like people who are hurting, and not like bad people, or getting scared of them, or getting, shying away from just walking alongside them and doing life together. So yeah, I appreciate all of your listeners, and I hope that they can kind of take that message of, this is not a shameful thing,
Yeah. Well, I definitely believe you have given us that message today. So thank you so much, Katie, for being here. I really appreciate it.
Thank you, Lisa.
Well, that wraps up another episode of The Therapy Show with Lisa Mustard. I know there are hundreds of thousands of podcasts out there, and I'm thankful you've chosen to listen to mine.
Be sure to visit lisamustard.com to access the show notes and discover more fantastic content.
And I'd be grateful if you subscribe to the show. Thank you.